So my topic is optical PK and triple procedure. To introduce penetrating keratoplasty is a full thickness corneal transplantation. It has the longest healing time amongst all keratoplasties, and it has the highest chances of rejection as well. So if you look at this data, this study showed that actually penetrating keratoplasty made up to 79% of the cases of keratoplasty that were done in India. In these, and out of which, of the total, 47% was optical PK. The trend is changing now. We are moving. A lot of surgeons are now adapting lamellar surgeries, with which have much better results. But if you take India's example, we have a lot of infectious cases. We have a lot of corneal ulcers, a lot of trauma cases where they are full thickness scars where lamellar surgeries will not be able to do justice. So these are the indications of transplant for PK in the study. Again, a lot of these indications have reduced with the advent of lamellar surgeries, but microbial keratitis and corneal scars post-trauma and infection is what we generally do. Sorry. So there are four prognosis cases. You need to evaluate them. Category 1 being the excellent cases, having a 90% success rate. These includes keratoconus, lattice and granular corneal dystrophies, and early stages of Fuchs dystrophy. But category 2 would be the cases with very good prognosis. Category 3 with the ones would be having a fair prognosis, 50 to 80% success rate, and the poor prognosis cases less than 50% would be cases you don't want to touch, like a case of a Stevens-Johnson syndrome or a pemphigoid and neuroparalytic diseases, etc. So these are the contraindications, and SJS and severe dry eye stand out over there. Coming to the preoperative assessment, you need to assess the visual potential of the patient by the past best corrected visual acuity, the age of the insult, the ocular alignment or fixation or presence of squint, and the projection of rays. You need to assess the cornea for its size and depth of the scar and the vascularization, the anterior chamber for any pars or iris defects, the status of the lens, and any vitreous in the anterior chamber. You need to also evaluate the ocular surface for dry eyes and also look at the adnexa. Preoperative investigations, ASOCT is sometimes helpful in locating the depth and extent of the corneal pathology, the looking for thinning, looking for any retrocorneal membranes, and sometimes anatomy also it shows, and the endothelium IOL distance and the regularity of the anterior chamber and the stability of the IL. UBM can also be done, but one thing that you must do if you cannot see the fundus is the B scan. Preoperative biometry would include keratometry, which you have to assume, I generally assume around 44 to 45. I put this question to the panel as well. What is the keratometry that you assume in cases of for optical cases such as this?
For me, I use 43.
43.
44 is what I use. Same. Whatever you use,
Yes.
you have to tell the patient that you're not.
Yes. Yes. So. And A scan you'll have to do ultrasound because optical will not get you the results. Anesthesia, most of us do use local and plus minus a facial block. But in pediatric cases, uncooperative adults, and in case of perforated corneas, a general anesthesia was what generally recommended. IV mannitol really helps, and the maximum effect is in the 30 minutes. A lot of instruments are required, the Trifines, the RK marker, the scissors, and the rest of the instruments are generally from the cataract set. You can use those. Of course, you need the donor cornea, and as Quresh sir mentioned, the flaring ring does help sometimes. I like to use this kind of a screw speculum because I can help titrate my pressure on the eye with it. Coming to the donor sizing or the trephinition in case of pediatric cases, aphakia cases, and with peripheral anterior synechia, I like to oversize my graph by 0.75 to 1 millimeters. In normal cases, I oversize by 0.25 to 0.5 millimeter. And in keratoconus, I generally go for the same size or oversize of 0.25 millimeter. Coming to the host sizing or the trephinition, depends on the host white to white. Generally, in cases of white to white less than 11.5 millimeter, I go for 7 to 7.75 millimeters of trephinition. Smaller in case of microophthalmos and larger in case of ophthalmos. So if the white to white is more than 12.5, then I would go for a larger trephinition such as 8.25 or 8.5. Of course, you need to look at the depth of the extent of the pathology and the size, cone in case of keratoconus, and you need to center it on the eye and not on the pupil. So coming to deciding the size, I like to mark, I like to measure the white to white and then go half of it and then mark right in the center so that so that I get the center of the eye. Uh, Following which I measure the size of the opacity, and then I put ink marks on the side also, so that definition also it helps me guide in that time. Uh, RK marker, I prefer to use an 8 RK marker. This helps because I don't want too much smudging of the suture lines. Uh, AC management is very important over here. So this was a case where I did a 9 mm trephination. This was a one-eyed patient. You need to cut with a side port knife, and then try to be as vertical with the cuts into the cornea as much as possible. I like to refine my donor after this step. And then it's very important to be breaking these iridocorneal adhesions, and you need to be very gentle and very friable over here, because any rough handling or something can just get the whole the iris out. So over here you can see there's a PCR, pre-existing PCR, and there's a fibrous capsular bag. I trimmed this fibrous capsular bag. There was some vitreous prolapse, and I first cut it, the bag with the scissors, and then did an automated vitrectomy over here. I tried to center this pre-existing IL, but it was a little difficult. At the end, I had to explant it, and once explanted, you can see that this IL was completely broken. Then automated vitrectomy was again done, and this syneculisis is very important, because to prevent, as Shivani will talk later regarding glaucoma management, it's very tough in such situations to manage them. So the next, I implanted a 3-piece IL over here in the sulcus, and you can see, and then pupilloplasty again, after which, about which Dr. Fogla will be talking about. So this, and then closure of the eye with the 4 cardinal sutures, and later on with the other 12 interrupted sutures, and then managing astigmatism with the keratoscope. In case of intraoperative bleeding, FND actually is recommended if you can do 15-20 days before this. I learned this from Fogla sir only, that you can give the cuts in the side of the blood vessels, and if the blood is coming to the center, it takes this blood away from the center. Covering the cataract management, sometimes it gets very difficult to do a rexis, so you might have to cut the anterior lens capsule with this with your scissors, and then dial the lens after doing a hydrodissection. You might have to dial this lens out of position, and then I prefer to use a Simcoe cannula, and with the Simcoe cannula you can wash out this, and then implant the IOL in the bag. Sometimes it gets difficult to implant because there's a lot of positive pressure. In such case, you can put your sutures, 7 sutures, put the IOL, and then put the 8 suture. This rim is sometimes a problem if like I have not got a good cut over here, so this can induce a lot of astigmatism. So you need to trim this rim properly for better apposition. In cases where there is sometimes debulking also helps to get a good visualization, and then you can have a much more controlled entry into the anterior chamber. Dealing with aphakia or subluxated lenses, as you can see, this lens just popped out. There was a capsular bag was there. It was all damaged. I removed it, did a vitrectomy, and then did an SFIL implantation by MYX technique. And this patient also did well. This is another patient I just recently did. This is the post-operative day 1 picture with previously failed 2 grafts elsewhere. This was a PK with an SFIL. Coming to suturing, interrupted and continuous is what you can do. So you can either do a torque or an anti-torque or a no-torque suture. The ideal depth is for 90% that you would require, and you would have the distance from the junction, graft host junction, between 0.75 to 1 millimeters. The reasons for poor outcome would generally be the poor compliance, particularly in a country like India, the preoperative condition of the patient, or the preoperative BCVA, surgical reasons, and also the poor quality of tissue. That is sometimes when you don't use it without evaluation of the endothelium, it is still being done in some centers in India. So for that. So to conclude, PK still has a very important role in today's scenario, particularly in a country like ours. Thank you so much.